Adrenal incidentaloma. Adrenal incidentaloma. Adrenal mass detected during abdominal imaging done for other reasons. Autopsy series, adrenal masses in 1.4 to 9%. Noted in 5% of patients who undergo CT scans. The adrenal gland. The adrenal gland. Differential diagnosis of adrenal incidentalomas. Cortical adenoma. Cysts. Hemorrhage. Myelopoma. Pheochromocytoma. Nalloneuroma. Adrenal carcinoma. Metastatic cancer. Granulomatosis. Tuberculosis. Histoplasmosis. Blastomycosis. Abscess. Amyloidosis. Fibroma. Two main questions when working up an incidentaloma. Is it a functioning mass? Is it a carcinoma? Is it a functioning mass? Aldosterone. Cortisol. Yas. Pheochromocytoma. Patient presents with hypertension and hypokalemia. Found to have a 1. Patient presents with hypertension and hypokalemia. Found to have a 1.3 cm left adrenal mass. Further workup revealed a high serum aldosterone and a low serum renin. What is this consistent with? Aldosterone secreting adrenal adenoma, Conn syndrome. Symptoms are often nonspecific hypokalemia. Hyperaldosteronism. Symptoms are often nonspecific. Hypokalemia. Weakness, cramps, polyuria. Hypertension. May be severe and refractory to treatment. Metabolic alkalosis. Primary hyperaldosteronism. Subtypes of primary aldosteronism. Aldosterone-producing adenoma. Idiopathic hyperaldosteronism. Primary adrenal hyperplasia. Aldosterone-producing adrenocortical carcinoma. Aldosterone-producing ovarian tumor. Familial hyperaldosteronism. Random PRA. NPAC. Random PRA. NPAC. PA equals primary aldosteronism, primary aldosteronism. If adrenal mass is greater than 1 cm, proceed with adrenalectomy. If mass is less than 1 cm, then recommend adrenal vein sampling. If lateralizes, then adrenalectomy. If not, idiopathic hyperaldosteronism. Is it a functioning mass? Cortisol. What is Cushing's syndrome? Hypercortisolism. ACT-dependent. Pituitary Cushing's. Ectopic ACT. ACT-independent, 20%. Adrenal adenoma/carcinoma/hyperplasia. Iatrogenic. List some features of the syndrome. Truncal obesity. Gonadal dysfunction. Hirsutism/acne. Facial fullness. Muscle weakness. Skin atrophy/bruising. Glucose intolerance. Edema. Cushing's syndrome. Really subclinical Cushing's. Rarely progresses to overt Cushing's. Found in mean rate of adrenal incidentalomas 8%. Incidentalomas less than 1 cm do not need WU for Cushing's. Since hypercortisolism extremely rare. Low-dose dexamethasone suppression test. Day 1. At 0900 take fasting blood cortisol. Immediately inject half a milligram dexamethasone. Give further half a milligram at 1500, 2100 and 0300 hours. Day 2. Day 3. The high-dose test is the same, using 2 milligrams. Cushing's syndrome caused by adrenal tumor. Low dose, no change. High dose, no change. Cushing's disease. High dose, normal suppression. Cushing's syndrome caused by ectopic ACTH. Is it a functioning mass? Yes, dehydroepiandrosterone sulfate. Secreted directly and almost exclusively by the adrenal. Signs of viralization in women. Hirsutism. Temporal balding. Voice changes. Clitoral enlargement. Acne. Increased muscle mass. Decreased breast size. Amenorrhea. Before we proceed, chromaffin. 1. The medulla is composed of underscore cells derived from the underscore neural crest. 2. Most extra-adrenal pheochromocytomas are located at the underscore organ of Zucker-Kahn, the bladder. 3. Patients with pheochromocytomas in underscore wall may present with underscore loss of consciousness due to catecholamine release. Post-voiding, pheochromocytoma secrete both epi and norepinephrine. Less than 0.1% of hypertensive patients. 85 to 90%, adrenal medulla. Men, multiple endocrine neoplasia. Type 2A, medullary CA, parathyroid. Type 2B, medullary CA, neuromas, marfanoid. Rule of 10. Familial. Malignant. Extraadrenal. Malignant. Sporadic. Bilateral, complications of pheochromocytoma crisis. Shock. Dick. Seizures. Rhabdomyolysis. Acute renal failure. Death. Pheochromocytoma workup. Labs. Electrolytes. 24 hours urine metanephrines. Plasma catecholamines. ANINT-MED, 2001 134 to 315 to 329. Urinary metanephrines above 1.2 mg/day, 6.5 micromoles/day. False positive results can very rarely occur. Labetalol. Buspirone. Caffeine. Imaging for pheochromocytoma. CT and MRI have higher sensitivity than 131 imibg. However, 131 imibg uptake is more specific. Some authors prefer to use MIBG as the initial screening modality because it enables whole-body imaging, makes it useful for detection of extra-adrenal tumors and metastatic deposits. The false negative rate of MIBG scintigraphy is 10%. CT-MRI still done. CT, quick/relatively inexpensive but not specific enough to distinguish masses. Hypertensive crisis after the injection of contrast material, reported. MRI, more specific than CT, but some patients cannot tolerate MRI. Pheochromocytoma. Is it malignant? PTs with known malignancy have adrenal mets at autopsy. Most common primary: breast, lung, kidney, melanoma, lymphoma. CT-guided FNA may be of value. Adrenocortical carcinoma, 0.5/million, incidence. 5-year survival. Localized disease, 70%. Metastases, 5.3%. Imaging, favoring benign. Small size. Round regular shape. Homogeneity. Low density on CT. Low T2 weighted signal. High lipid content. Imaging, favoring malignant. Large size, greater than 5 cm. Irregular shape. Heterogeneity. High density on CT. High T2 weighted signal. Low lipid content. Demonstrable growth size. It does matter. The probability of malignancy increases with size. At the cutoff of 4 cm, the male/benign ratio, 8:1. Recommendations: remove all lesions greater than 4 cm. It is non-functioning and less than 4 centimeters. Now what? Adrenal incidentaloma.